Hey there, and welcome. I'm Anna Hartman, and this is Unreal Results, a podcast where I help you get better outcomes and gain the confidence that you can help anyone, even the most complex cases. Join me as I teach about the influence of the visceral organs and the nervous system on movement, pain, and injuries, all while shifting the paradigm of what whole body assessment and treatment really looks like. I'm glad you're here. Let's dive in. Hello. Welcome back to another episode of the Unreal Results podcast. I filmed an episode yesterday, and it was like the first episode back from like having a few weeks off. And I was like thinking, I was laying in bed this morning and I was thinking about like the previous episode. And I was like, oh, that was like the end of the year wrap up. And I was like, I shared about, shocker, my eyes. And I was in the in-between of the ophthalmologist basically like nonchalantly being like, oh, you might have early onset glaucoma, but no big deal. So I had shared like my strategies that I was going to be using to like address the ocular hypertension and, just navigate that, like some supplements and stuff I was taking. So, but when he had said that nonchalantly, he had been like, I don't, we have to do more tests, basically. He has no idea that I am like a healthcare person. And so like, I think he didn't realize when he like kind of nonchalantly basically said I had the beginning of a glaucoma. Like, I don't think he realized that I actually knew what that was and like all the information about it. But he was also like, well, there's more tests we need to do. So come back in a month and we'll recheck things and do the other tests. And so my follow-up appointment was the like first or second week of January. And when he remeasured me, my pressure was down. And so it's still on the high side. Like it's high, it's in the normal range now, but it's high. And so he still doesn't love that. But then they also redid my peripheral vision test, which is like one of the best tests for optic nerve function. And then they also took a picture of my optic nerve. And the peripheral vision test I had done previously, probably like a year before, and it was normal then during the throes of pink eye. And then it was normal the other day when I did it. And so it really hasn't changed. So he's like, yeah, that's really good. Like, and then the picture of my optic nerve, like even as the lady took the picture, she's like, oh, it's beautiful. And I was like, oh. So, and he said it looked good too. So, I don't know what that means. I didn't ask him like what that means with the measurement of the nerve that he took that made him believe that I was like borderline atrophy for the optic nerve. But it's good that it looks good. It's functioning well. And then also great news that my eye pressure has come down. Of course, he doesn't think it has anything to do with what I've done, but disagree. Agree to disagree. So still having to go back to see him every 3 months for a checkup. He wants to just redo my peripheral vision tests and pressure tests every 3 months just to make, monitor it for a little bit and make sure it is not progressing towards that direction. So a couple of you have asked me or like sent me messages regarding optic nerve stuff. And so it just made me realize like, oh shoot, I never gave you an update. The other thing that was interesting previously when he kind of nonchalantly threw that out about the glaucoma, he had told me that the good news was the white spots on my cornea were gone from the infection. And he's like, well, you could stop the medicine and you can, like, we won't put the plugs in your tear ducts, and we'll see how you do. He's like, you'll probably still have dry eye problems, but, we can try it, which is so wild that he wanted to stop both of the things at once. Because then it's like, you don't know which one was which. So since he didn't put the plugs in, I stayed on the medicine. And then in the follow-up in a month, first of all, that month was significantly harder for me from a dry eye standpoint. I went through so many eye drops and I was just so uncomfortable over that month. And so it was very clear to me that the plugs actually make a huge difference. So I asked him to put the plugs back in and like immediately felt so much better. So I'm going to use the medicine until I run out and then keep doing the plugs. And that's another reason why I have to go back every 3 months, because the plugs only last for 3 months. So once I run out of the medicine, I'm going to maintain just the plugs, and then we'll see if I can go without the medicine, because it's pretty expensive and it also kind of burns when I put it in my eye, which doesn't feel very good. So we'll see. There's potential that when I stop that medicine, the white spots could come back. So we'll see. But anyways, that seems like a smarter way to go about doing it than just stopping everything at once. So that's my eye update for you. I'm definitely less concerned, though I don't love that. I have a little bit of a high pressure still, even though I'm in the normal. So it just, again, I'm going to continue to do all the things that I know to change the pressure in my cranium, and assume that if I'm changing the pressure in my cranium, I'm also changing the pressure in my eye, and then continue to work on like all my lymphatic drainage things that are going to support that eye health as well. And I'll keep you posted. So, all right. So this episode is actually so inspired by a question that we got that the group, well, somebody in our plyo intensive group had, and it got my wheels turning and thinking about like, yeah, how would I support that? So it was really interesting. We were, the woman was talking about how adding in plyometrics to her programming for some of her clients who had osteoporosis, she's seen some really good changes in their osteoporosis, improve, like their bone health. And so the interesting thing was a lot of the areas of the bone that were osteoporotic showed improvement, except the femoral neck. And so her question was there a different way that she could target the femoral neck with different exercises, different plyometric variations, that maybe they weren't getting that stimulus in the right area? And for me, when I heard that, I was like, ooh, interesting, because I would think that if the stimulus was enough to remodel bone in like the shaft of the femur, and I forget where the other parts were, but in the other areas of the bone in the skeleton that were osteoporotic, like why was the femoral neck not responding? And I mean, it could be a vector issue, it could be a loading issue, but my thought process is if the loading was enough to remodel bone in other places, like what else could be the issue for a lack of remodel in that area? And it made me think about some of the athletes that I've worked with, the people that I've worked with that have had fracture healing problems, like non-union fractures, or they had some sort of fracture where the doctor had to go in and do a internal fixation with, plates, screws, etc. And they're trying to get those out, but the bone was not healing properly. And what often comes up in those cases is a diminished blood flow to the bone that is healing. And not just a diminished blood flow because of the area of the bone, right? Because some non-union fractures are happening in areas of the bone that don't have good blood supply. So examples of that is going to be like a fifth met fracture, like a Jones fracture, or a scaphoid fracture in the wrist. Those two bones, and there's other bones like that in the body too, but those bones inherently don't have a good blood supply throughout the bone. And so then when you fracture in those areas, you have to have internal fixation to keep the bone together because the healing is so delayed from a lack of blood flow. But then there's been just incidences in other areas of the body that people have broken their bone or had a stress fracture, and is just taking longer than the doctor would like to see a callus forming and like bone remodeling. And I'll see this often when people are like, they have the massive fracture. They get the internal hardware to fixate it as they're healing. And the doctor told them, that they eventually could get the hardware removed, but like the bone's not showing that it's ready for that yet. And so they're like so frustrated because oftentimes the body does not like that hardware in it and it's painful. And so they really want to get that hardware out, but bone hasn't healed yet, so the doctor keeps pushing it back. And so I've seen them and been able to improve blood flow to the area, and within a couple weeks actually see changes in the bone healing on the imaging. And so that's been pretty powerful. And the way that I really have assessed that is through monitoring people's distal pulses of their limbs, and with the assumption that if you have a good, robust, resonant distal pulse, that is indicative of good blood flow throughout the body and throughout the limb, especially the involved limb. And so I don't think it would be any different in the case of osteoporosis, right? We need blood flow to the area to help with the remodeling of the bone. And when it's limited, it's going to be very challenging no matter what stimulus you place on the bone to create that bone growth stimulus. So what I did for the group, is, I gave them my thoughts on like, this is what I think it's a blood flow issue. And also there's so many areas that around the hip joint and around the pelvis that arteries and nerves get entrapped, that I'm like, I would bet money. I'm not a gambler, but I put money on the fact that there's some sort of neurovascular entrapment going on that is decreasing blood flow to the neck of that person's femur. And if you could target those, you might see a better response with the plyometrics you're already doing. So I put together like a whole handout for them, for the people in the group, of like, here's what I would try if this was my patient. And so I wanted to share that with you today on the podcast and talk a little bit more about the femoral neck and blood flow to the femoral neck, to the hip joint, the coxofemoral joint, and give you some practical ways that you could go about affecting this. Now, is this only useful for people with osteoporosis or like femoral neck fractures? No, this is great for just general hip function, general hip mobility, like freeing up the neurovascular structures at this area of the hip is not only going to affect the hip, but it's going to affect the SI joint. It's going to affect the pelvic organs, the pelvic floor, the knee joint, the ankle. Like literally, it's going to affect a ton of structures. So these are really high payoff spots that I end up treating my athletes quite a bit. Sometimes I find that the areas of entrapment of these very important neurovascular structures are around areas of the pelvis that traditionally most people, manual therapists, avoid touching because it's near private areas. And now I'm not saying like carte blanche, just go palpate away in here and like do a million massage techniques in here, because consent matters and reading the room matters and your comfort level matters and the patient's comfort level matters, your scope of practice matters. But I'm also saying that if you're a healthcare provider and it's within the scope of your practice and you're still weirded out about touching these areas, you have some work to do, because it's such important anatomy and it's such important areas that need treatment. Like you really can't avoid it. And if at the end of the day, if you truly want to avoid it because you truly feel uncomfortable or your patient population is just not okay, then you need to understand still at least the anatomy so you can provide self-massage strategies or exercises or movement strategies that'll target the same tissue in the area. Is it often as good as manual therapies? Specific and precise manual therapy? No. General manual therapy? Yeah, it's probably just as good. So, that's a little bit of a bid too. It's like, again, and like, that's what I mean too, is like, I don't want anybody just like digging around in these areas. You need to have an informed touch. You need to understand a precise treatment and know that there are practitioners out there with those skills, and or classes you could take to gain those skills. And, but at least starting at a fundamental understanding of the anatomy and a fundamental understanding of where that is on the body, I think is super important. So let's kind of dive into that. So I did, and I'll make sure Joe links basically the handout I gave everybody in the Plyo Intensive. I'll make sure Joe links all these things in the show notes for you too. Two of the things I linked was 2 anatomy resources. The first one is a journal article. Proof that I read journal articles. People always think I don't. I'm not evidence-based, but I literally study anatomy like every day. And when I study anatomy, it's not just looking at pictures. It's usually reading anatomy journal articles like this. So this journal article from the Biomedical Journal of Scientific and Technical Research it is an article called The Hip Joint, Embryology, Anatomy, and Biomechanics. It's a great article, actually. Really, number one, it's free. We always love free access, open access research articles. It was published in 2019, but it goes through everything like embryology and then all the pieces of anatomy. And so when we look at specifically the vascular anatomy, it's helpful to understand kind of like where the blood supply is coming from and then understand even further up the chain what's going on. So it basically says the hip joint receives its blood supply from several sources. The acetabulum, so the pelvic side of the hip joint, is supplied by 3 main arteries: the obturator artery, the superior gluteal artery, and the inferior gluteal artery. The superior gluteal artery supplies both the superior and posterior portions of the acetabulum, and the inferior gluteal artery supplies the inferior and posterior portions. And it goes and it continues to talk about the acetabulum. So now what we really care about, specifically for this femoral neck issue, is arterial supply to the proximal end of the femur. So, and it, as with many important body parts, it's a redundant blood supply, meaning that there are multiple arteries going to encapsulate the entire femoral neck, the entire femoral head with blood supply. So I'm not sure about you, but like when I was a student in school, I remember learning about like if someone dislocates their hip and tears the ligamentum teres, that's like a main blood supply to the femoral head, and then your femoral head will die and you're screwed. And it's like, yes, that's true, but also there's a little bit more redundancy in the hip that is not as detrimental as maybe they made it believe. Is it still not a good thing? Absolutely. But there's other blood supply to the femoral head than that. But when we look at it, basically it's divided in multiple different ways. But at the end of the day, what happens is the blood flow that comes to this area is basically from the medial circumflex femoral artery and the lateral circumflex femoral artery. That is what is supplying the majority of the femoral neck with blood supply. The obturator artery supplies the artery to the ligament of teres, and also supplies to the head of the femur, where these medial circumflex and lateral circumflex femoral arteries not only supply the femoral neck, but they also supply the femoral head with blood supply too. So that's a little bit of this redundancy I talked about. So what we're caring about when we're talking about the femoral neck is this medial circumflex femoral artery and the lateral circumflex femoral artery. The medial circumflex femoral artery, especially, I think, is the greatest area to target here. When you're looking at the pictures of the anatomy, you really do see how much more of the branches really come from the medial circumflex artery, and that comes off of the femoral artery as it travels through the tendon of the hip flexor, the iliopsoas. That also, I think the other piece of it, well, not even the other piece of it. The other part of like my target strategies was to the obturator artery, in the obturator area anyways, because two reasons. Because of the role on the acetabulum and the femoral head, but then also when you look up the chain, right? Whenever we're talking about vascular entrapments, there is the obvious vascular entrapment of the final area right before it gets to the femoral neck, which is through the iliopsoas tendon. But farther up, we have entrapment areas that are possible in the inguinal canal. We have entrapment areas that are possible in the pelvis itself. And any bit of pelvic congestion is going to really have a potential to diminish or entrap blood flow of the of this downstream branch of the femoral artery. In the pelvis, right above the inguinal canal, that artery is in either the internal or the external iliac artery. And then above that is a common iliac artery, and then it goes into the aorta. So there's areas in the abdominal cavity and in the pelvic cavity that these can get affected as well. And so we want to make sure that you're kind of addressing all of these spots, right? The local areas, but then when we're affecting, especially when we're affecting the area where the obturator artery comes out, which is at the obturator canal, the area of the obturator canal is also an area where the adductor mangus, the adductors, connect into the pelvis, and what's the right word? Anastomose or interdigitate or become continuous with the pelvic floor fascia. And the pelvic floor fascia is going to be on the external side of the internal pelvic fascia, which is the endopelvic fascia, which is a very, very rich vascular network of veins and arteries. And so this is why when we can affect that sweet spot at the obturator canal, at that medial side of the hip joint, we clear up a lot of possible entrapment sites. So where I have listed, and you'll see by reading this anatomy article and looking at this, the other anatomy resource I gave is like somebody put together a blood flow to the femur head slide share. So I included that because it had some good pictures of it. But what you're going to see is vascular entrapment areas that are possibly the iliopectineal ligament, the inguinal ligament itself, the pectineus and iliopsoas muscles or tendons, the quadratus femoris, that is an area that is going to affect the lateral circumflex artery. The sartorius is a common entrapment site, as well as the proximal rec fem. So all of these, that's going to be for the lateral circumflex artery as well. So a couple of these for the medial circumflex, and then a couple of these for the lateral circumflex. The general pelvic congestion is going to really affect especially the internal iliac artery and the obturator nerve arteries, as well as the femoral nerve artery. The inguinal ligament itself. So here's another connection from pelvic floor, right? Going back to the adductor mangus and why opening up the adductors is going to be really helpful to affect the pelvic floor, because when we have a lot of tension in the pelvic floor, right? Here's a pelvic floor here. When we're a tight ass and our ischial tubes are kind of coming narrower together, what happens is that the inguinal ligament on the front side has a little extra compression across it. And that extra compression of the inguinal ligament is going to have a tendency to have an entrapment of the femoral nerve or femoral artery itself as it transverses underneath in the adductor canal, and also have more of a tendency to press on the iliopectineal ligament. The iliopectineal ligament is a ligament underneath the inguinal canal that maintains the space at the top of that adductor canal, so that when we go into hip flexion or hip extension, we're not compressing the femoral artery. So that's a real important thing to know, that one of the ways to treat that is not just going to be treating directly at the inguinal canal or directly at the iliopectineal ligament here. It's going to be actually to treat the pelvic floor to take that stretch off of it in the first place, right? So again, pelvic floor mobility is going to be really helpful in this sense, to have more of a reflexive effect on the inguinal ligament, the iliopectineal ligament, as well as the blood flow to the pelvic arteries, which have such a connection to the femoral neck. So, huge pieces. Where do I want to go with this? The internal. So the internal iliac artery is actually one that's like really hard to palpate because it's very deep in our abdomen. But in general, it is in general about 3 fingers below where the aorta, abdominal aorta, bifurcates. It's like so medially and caudally. So towards the midline and down towards your feet, 3 fingers below the aortic bifurcation. You can find the aortic bifurcation pretty easily because it's pretty easy to feel such a loud pulsing of the abdominal aorta. Sometimes it's right around the belly button. For some people, it's a little higher. For some people, it's a little lower. Everybody's different where the bifurcation is. You're going to feel pulse, and then all of a sudden the pulse goes away. Right below it, that's right where that bifurcation is. So if you can find that aortic bifurcation, then to find the internal iliac artery, you'll just go down on a diagonal, a little bit of a diagonal, 3 fingers, and you'll kind of push in and feel a very light potential for a very, very light pulsing. So we learn a technique for this in the visceral vascular manipulation class for the Barral Institute, but it's very hard to feel. So, but what this tells me is it's again a reason for just some general visceral self-massage in this area, or even the need to do like a generic belly button technique to address general tensions of the visceral container in this area. Because if you change the general like space or like, awareness in this area, you have the potential to change some blood flow without even doing a visceral manipulation technique. Also coming from the sides of the body and like bringing things into a direction of ease can be very powerful for this. So, if it's the side, what this would look like is what I would probably start with is some visceral self-massage, like sideline Corgis ball self-massage, laying on the side of the femoral neck that is the concern. If it's both sides, you'll just do both. You can also just do both anyways, but this is going to push sort of everything medially and kind of like slack things to give them space to work themselves out. And then when you let go of that self-massage, then it goes into like a little stretch. And you could even add a little sensation of a stretch by bringing your spine up into extension, side bending away, rotating away. You can add that, because at the end of the day, vascular structures do love to be stretched. So that is internal iliac artery. Inguinal ligaments treatments, I'm going to be doing pelvic floor mobility. In the pelvic floor mobility I love is like self-massage with a soft ball. You could do just a prone stretch of the adductors. You could do a supported adductor stretch, like a frog stretch. You could do a standing or a half kneeling hip flexor type stretch with your leg out to the side, focusing on that like hip abduction. There's a lot of options that you have from a pelvic floor standpoint. And in the I'm like, did I even give these? I don't even think I gave one example of the self-massage with the ball. That is like my go-to. That's the sweet sauce. And the reason I like that too, and it's like the go-to, is because it also sort of helps your body map where your pelvic floor is, where your sits bones are, what the base of your pelvis like is, right? And having that understanding in your brain as the client, it really helps to like have a little bit of awareness, even from a movement standpoint, when you go into a movement standpoint, like where you should feel the stretch or the opening of the pelvic floor. The other things, obturator nerve guide really helps to mobilize the pelvis in general. It also reflexively affects the visceral container of the pelvis, because the obturator nerve is one of the nerves that innervates the peritoneum. Hip flexor release, especially targeting around the obturator canal, right above the medial insertion of the inguinal ligament, great high payoff spot. The other end of the adductor canal can be really powerful as well. This is going to affect the adductor mangus. This is going to affect the sartorius. So you're going to have an effect on the medial circumflex artery as well as the lateral circumflex artery. Then hip medial glide, prone frog stretch. These are all great for improving hip abduction and, again, opening up that real sweet spot in the medial pelvic groinish area that is going to affect so much, not only of the medial hip itself, but of the pelvic floor, and really affect that blood flow in that area. So kind of a lot. I mean, I know I'm throwing a lot of anatomy at you, and that's is why it's like definitely check out the show notes for not only the anatomy to look at, but then also the exercises I gave. But this is a big piece. And actually what I would check, but the before and after I would check, besides like just general hip flexion, passive hip flexion would be really interesting to check, because what happens often when you free up the space is all of a sudden when you go to flex the hip, it becomes like really loosey-goosey. Like as you move into hip flexion, you just feel the femur like free to rotate in the socket. Like zero resistance moving into hip flexion. So that's a really good sign. And then the other thing I would test pre and post interventions is the distal pulse. So the posterior tibialis pulse, which is the pulse right behind the medial malleolus of the ankle. I want to see if I can make that feel more robust. The femoral nerve or the femoral artery pulse, you can check that before and after, but I think it's less indicative of a big change in the entrapment than the posterior tib pulse. The posterior tib is a little bit more reliable, because especially since we're doing treatment in the area of the femoral artery up at the groin area, it's just like you don't know if it's just post-treatment artifact or like actual good changes of blood flow in that area. So I actually think a more distal pulse is going to be more indicative of if you made a big change to the blood flow in the entire leg. So, but also it's like, don't take my word for it. Just check them both. But I think your work is not done until you've changed the pulse at the posterior tip. And with this said too, a reminder that all of this is great, but it could be a blood flow entrapment issue even higher up the chain from something else, somewhere else. Could be more visceral. I mean, obviously, I talked about how pelvic congestion can play a big role in the blood flow to the hip. And so that's a big piece. Like, is there pelvic? You could have pelvic congestion from a liver issue and a backup of the portal vein and the balance between the liver and the lower part of the colon. And I talk about that in I'm sure I've talked about it in multiple episodes. I've probably talked about it in the swelling episode. I might have talked about it I know I talked about it in the episode that talks about the liver and right shoulder pain and left sciatica. So I'll have Joe link that in the show notes. I probably also talked about it in the episode about constipation. So this blood flow problem to the femoral neck can be somewhere other than these most related entrapments. And this is why we use an assessment like the LTAP to direct us where to go. But the thing that I'm going to really care about always in relationship to femoral neck issues is, how does it change their hip flexion mobility? Can I free it up to find that nice loosey-goosey rotation? And then also, how does it affect their distal pulses? Because I want to know I had an effect on the blood flow. Because the LTAP might take you somewhere else, which is good and valid and helpful for them, but you still may have work to do around the hip itself. So you can't just assume that where the body takes you is the only place you need to do treatment. It's just you have to go in the sequence that the body wants. I can't just dive into these entrapments around the hip. I mean, I could dive into these entrapments around the hip, but they're not going to stick. They're not going to stay if I don't do it in sequence with the other more important things that might be up or down the chain. So I let the body direct me in the sequence, but understanding all these possible areas of entrapment, all these possible interventions that I could do that could have an effect on improving blood flow to the area, this opens up a lot of treatment connections and treatment options for me when we do get to the point where the body's like, yeah, do treatment wherever you want, or directing you to these spots specifically. So I know that was a lot in a really short period of time, but like I said, I'll have Joe link in the show notes the handout I gave everybody so you can kind of see it, and then have fun. Let me know how it goes. I love this kind of thing. I love these kind of troubleshooting cases. So yeah, totally different perspective of an answer for like what to do for osteoporosis, right? The load is so good, but if we don't have good blood flow, we're not going to maximize the effects from that load. This is what it's all about. Have a great day.